Hi, I'm Jane Andrews. I'm a gastroenterologist. I look at a lot of different health problems, but they're all to do with gastroenterology, so to do with gut health. And most of my research is looking at problems that are experienced by people with Crohn's and UC. In terms of looking at the problems for people with Crohn's and UC, my work is really around clinical medicine and clinical outcomes and making their care more effective and more efficient and actually improving things that we often don't think to look at. So how your brain feels affects your gut and vice versa, and how your gut feels will influence how you feel. It's not surprising. So at the moment we're about to start recruiting. I think we might have got our first 1 or 2 patients in for screening to look at whether a psychological intervention influences disease activity. So we're going to add on hypnotherapy as a trial to patients with active Crohn's disease, so they can receive normal Crohn's therapy as usual, but some people will get hypnotherapy as an additional treatment adjunct, and that's going to be undertaken by our health psychologist and some of our other researchers in the department, and they're going to look at some biological outcomes as well in terms of stress hormones, so that we get not just subjective ratings of whether the patients felt better or liked it, but also whether we change some sort of physiology or biology. So that's just starting up now. We're also looking at some ongoing work to see whether different treatments that we use for inflammatory bowel disease give different outcomes in terms of weight gain, because weight gain in modern society is a problem, and weight gain for inflammatory disorders is a problem, because patients can get additional problems like, cardiovascular disease, risk of diabetes, osteoarthritis, fatty liver disease from their therapies if their therapies are worsening their weight gain. And weight itself can worsen inflammatory disease. I think the benefits are manifold, and I think that the benefits from some of the work inform how we can deliver the care better. That will always benefit patients, because if we're delivering the care better, we're able to deliver, better care. And so that means people will feel better emotionally, psychologically. They'll also feel better because their disease will be under better control. So they won't be having the complications from their therapies or from their disease. And in inflammatory bowel disease, if you get a complication, then you're usually going to be admitted to hospital. So you'll be feeling unwell, there'll be time off work, time away from your family. You'll often be having an operation. That will often mean that you're losing part of your bowel. That may mean that you get a stoma and that you have a bag forever. And that has really big consequences for a lot of people. We can understand that. These are often young people. Some of them have not yet finished schooling. Some of them have not finished studies. Some of them have not yet found their life partner or had their family. Having a bag, or even just the fear of having a bag and the fear of having cancer, even though it's a very low risk, it's something our patients worry about. So if we can minimise the chance of that happening and we can communicate that well with our patients, then they spend less time worried and more time having a normal life, which is what we expect for them and what they want. And that gives it a societal benefit, because in health, a lot of what leads to people not feeling well is not the actual disease, it's our experience of the disease. And the experience of the disease will be influenced by worry, by anxiety, and by stigma. And so if we can reduce all of those things by communicating better, or reassuring people that complications are really low, we might know they're low medically, but if we can't get that information to people well, and also demonstrate that we're saving those outcomes, then people remain worried, and that's an opportunity cost. One of the people who's really benefited actually appears in my email signature byline, and he benefited from one of our initial mental health projects. There are a number of people though. I can think of a lovely young woman who, although she ended up having surgery and getting a bag, she went on to having a modelling career and swimming in a bikini down at Victor Harbour with her bag on, and no embarrassment, no shame, and was very pleased to get it out there. Going back 50 years, we didn't have such long life expectancy. We didn't have as many good drugs. If you had a bit of a tummy ache, but the guy next to you had polio as a child, you weren't going to whinge about your gut ache, and the doctor wasn't going to be very sympathetic. So as we live longer, no, it's serious. I mean, as we live longer, we're healthier, we're kind of less tolerant of any problem, then we're going to complain more about the ones we do have. Most people, like gut symptoms are really common. Most of them don't mean anything apart from that your gut doesn't feel comfortable. They might mean that you drank too much last night, that you ate too much, that you're too fat, that you shouldn't have had all that fatty food. We're eating a lot more crap, we're fatter, we're not exercising as much. Yeah, that's all going to make your gut feel unhappy. But real gut disease, like where we can see a problem that's going to shorten your life, some of them are getting more common, but some are getting less common. So for gastric cancer in women, less and less common. Great news, okay? That's good. But for gastroesophageal cancer in fat, older white men who smoke, more common. But there you go, don't get fat, don't smoke, So a lot of the things are lifestyle related for sure, but a lot of people want short-term fixes like the fast food fix for the symptoms, but actually it's the fast food causing quite a lot of the symptoms. For gut health, for the general public, it is what your grandmother told you, that you need to eat healthy food, you need to get regular exercise, and you need to not get fat. The other, smoking, but that's never good for anything, okay? There's not a single disease that smoking is ideal for, and I don't think you'll find any doctor who'll recommend it. You only actually have to look at what we do. Doctors on average exercise regularly. Doctors on average, compared to most other professional groups, have normal BMI, and we don't smoke anymore. So don't do what anyone says, do what we do.